All right, welcome everyone. Let's get right into it. Today, we're diving into a rigorous academic explainer on the latest pathogenesis and treatment updates in atopic dermatitis, straight out of the recent EADV 2025 symposium and the latest literature. Now, as a senior dermatologist, I can tell you firsthand that the landscape of this disease is evolving faster than ever before. We are literally shifting from older, empiric treatments to highly targeted molecular therapies. So grab your notebooks because we're going to unpack the scientific basis, the immunology, and the real-world practical implications of these updates for your daily ward rounds and, of course, your upcoming practical examinations.
Here is our roadmap for this session. We'll start with definition and epidemiology, move into immunology and pathogenesis, look at clinical features and differentials, then cover investigations and guidelines, topical treatment algorithms, and finally, wrap up with systemic and biologic therapies. Let's get started.
Okay, Section 1, Definition and Epidemiology. Let's establish our baseline right away.
Now, defining moderate atopic dermatitis is one of my absolute favorite Viva questions. You need to remember that modern clinical trials have completely shifted away from the older Rajka and Langeline criteria. If you want to get your patient approved for a modern biologic or an oral JAK inhibitor today, you have to master the strict cutoffs shown here. We're talking an Eczema Area and Severity Index, your EASI score, of 16 or greater, an affected body surface area of 10% or more, and an investigator's global assessment of 3 or 4. This is a huge stumbling block for residents. You can't just eyeball the patient anymore. You must quantify the disease burden accurately, because reimbursement and modern treatment algorithms rigidly depend on these exact numbers.
Moving right along to Section 2, Immunology and Pathogenesis.
When we get down to the molecular level, knowing your cytokines is absolutely non-negotiable if you want to understand how our targeted therapeutics actually work. As standard texts like Bologna clearly lay out, the T helper 2 axis is the center of the universe for this disease. Look at step 1, interleukin-4 and interleukin-13. These are the primary drivers of the inflammatory cascade and that classic epidermal barrier dysfunction. Step 2, interleukin-31. Think of this as the master itch cytokine. But here is the absolutely crucial clinical pathological correlation you have to grasp. Step 3. These extracellular cytokine signals don't just float around. They converge intracellularly, relying heavily on the JAK-STAT signal transducers, specifically JAK1 and JAK2. Once you understand this convergence, you understand exactly why blocking JAK pathways therapeutically shuts down both the skin inflammation and that intense pruritus almost at the exact same time. It's brilliant.
Next up, Section 3, Clinical Features and Differentials. Clinically, you must recognize that atopic dermatitis is a systemic inflammatory condition. It can have severe, literally life-threatening cutaneous presentations. A classic complication you are definitely going to see on the wards is erythroderma, involving over 90% of the body surface area. Now, a very common, very dangerous mistake residents make here is focusing solely on the rash. They prescribe topical steroids and completely neglect the patient's hemodynamics. Don't do that. These patients are losing massive amounts of heat and transepidermal water. They are at high risk for hypothermia and hypovolemia. Your immediate intervention has to be fluid resuscitation with crystalloid solutions. We're often talking a 500 milliliter bolus in under 15 minutes, along with strict temperature control in a 30 to 32 degrees Celsius room. Also, remember that compromised skin barrier? It's a prime target for secondary bacterial infections, especially Staph aureus. So get those local cultures and start appropriate systemic antibiotics. Bottom line, treat the patient, not just the skin.
All right, Section 4, Investigations and Guidelines.
To properly manage these patients, we have to rigidly stick to validated scoring systems. For your practical exams, you must be completely fluent in these tools. Using EASI, IgA, and body surface area is mandated by standard global guidelines to help us move up or down the therapeutic ladder. But please, don't forget the subjective burden. Itch is usually the most debilitating symptom for the patient, which is why tools like the Patient-Oriented Eczema Measure, or POEM, are so vital. Furthermore, pediatric quality of life indices, like the CDLQI and IDQL, tell you what the EASI score simply cannot. They measure the psychosocial destruction of the disease. We're talking school absenteeism, profound sleep disruption, and the immense, crushing stress placed on the entire family unit.
Which brings us to Section 5, Topical Treatment Algorithms. Let's look at the cornerstone of our management.
If an examiner asks you in your practicals why the newer small molecules are so effective, you need to hit them with the 500 Dalton rule. Basically, a molecule generally needs to be 500 Daltons or smaller to effectively penetrate an intact stratum corneum. Look at the comparison here. Tacrolimus is a large molecule, coming in around 800 Daltons. Technically, it shouldn't penetrate well, but it does in atopic dermatitis specifically because the epidermal barrier is already defective in these patients. However, our newer targeted agents, like ruxolitinib and crisaborole, are engineered to be around 300 Daltons. This is the optimal therapeutic size. It allows for highly successful, highly predictable epidermal barrier penetration regardless of how inflamed or intact the local skin is, which is a profound advantage.
I want you to carefully trace the pathways on this algorithm from the recent guidelines. Notice how it splits based on disease location. For acute, mild to moderate flares on standard body areas, we go with our low to medium potency topical corticosteroids. But pay attention to the pathway for sensitive areas, the face, the intertriginous zones. These are places where steroid atrophy is a major risk. Here, the algorithm smartly shifts. We transition over to topical calcineurin inhibitors or newer agents like the topical JAK inhibitor 1.5% ruxolitinib cream applied twice daily. And crucially, look at the maintenance phase branch on the right. Notice the shift towards proactive, twice-weekly application of anti-inflammatory agents to prevent flares before they start rather than just reacting to them once the patient is already miserable.
Now this graphic brilliantly illustrates the European counterpart. Notice how the Euroguide Derm Pyramid maps out an excellent escalation pathway from the bottom up. We start right down at the foundational green base with basic emollient therapy. By the way, basic emollients making the WHO essential medications list was a massive global milestone. From there, we move up to reactive and proactive topical therapies. Then, when baseline control fails, or if the disease is just too severe right out of the gate, the apex of the pyramid directs us up to conventional systemic drugs, think cyclosporine or methotrexate, and directly to the targeted biologics and oral JAK inhibitors. This is your clear visual roadmap for modern dermatological decision-making.
So let's look at the actual data driving these guidelines. If you examine the primary endpoints on this TrueAid 1 and 2 sub-analysis, you'll see the sustained efficacy curve plotted out over time. The big takeaway mapped here is that 1.5% ruxolitinib cream achieved an IGA of 0 or 1, meaning completely clear or almost clear skin in nearly 80% of moderate patients over the 52-week extension phase. 80%. Furthermore, the corresponding line shows a dramatic sustained reduction in the mean percentage of body surface area affected. The practical so what for you on the wards is that optimizing topical therapy with these advanced small molecules can actually delay or even entirely prevent the need to escalate to heavier systemic drugs for a huge chunk of your patients. Finally, Section 6, Systemic and Biologic Therapies. What do we do when topicals just aren't enough? This table right here summarizes our heavy-hitting systemic options. Dupilumab, an interleukin-4 receptor alpha monoclonal antibody, has been a real game-changer. It broadly inhibits type 2 inflammation and has totally revolutionized pediatric care, boasting a proven safety and efficacy profile in infants as young as 6 months. Now, oral JAK inhibitors. They offer incredibly rapid pruritus reduction thanks to that intracellular blockade we talked about earlier. However, you have to be vigilant with continuous laboratory monitoring for lipids and hematological parameters. And, of course, our conventional broad immunosuppressants like cyclosporin and methotrexate are still vital tools. Here is a postgraduate pearl for you. Cyclosporin is highly effective as a rapid bridge therapy to get a severe flare under control quickly, but you must rigorously monitor blood pressure and renal function. We typically limit its continuous use to just 1 to 2 years to prevent irreversible nephrotoxicity.
I want you to read this quote. As highlighted across all the recent literature, we absolutely have to undergo a paradigm shift in our thinking. You are not just treating an isolated skin rash, you are treating a complex, systemic inflammatory disease. Untreated or undertreated atopic dermatitis carries a cascading risk of atopic comorbidities, things like asthma and allergic rhinitis, which we often call the atopic march. Not to mention the severe non-atopic comorbidities like chronic sleep deprivation and immense mental health burdens. Comprehensive care means we have to mitigate these systemic risks aggressively.
All right, I'm going to wrap up this session with a classic case-based Viva challenge to leave you thinking. A patient arrives on your ward. They have over 90% body surface area erythroderma, severe pruritus, elevated LDH, and an IgE of 497 international units per milliliter. So what's your move? How do you clinically and histopathologically differentiate an erythrodermic atopic dermatitis flare from psoriasis or, say, a cutaneous T-cell lymphoma like Sézary syndrome? And critically, how does that exact diagnosis dictate your immediate life-saving systemic interventions? Think about it. If it's psoriasis, you might reach for methotrexate, But if it's caesary, your approach shifts entirely. I want you all to crack open your Rook's textbook of dermatology tonight and review this specific histopathological differential. Thanks for your attention, everyone, and I'll see you on the wards.